for me, at least, staying focused on the patient as my North Star, regardless of the role, brought a lot of clarity and ease in terms of decision making. Now, it didn't necessarily make things easy to accomplish, but then a lot of other things automatically kind of fell into place in terms of what needed to be done, how it needed to be done, how it could be done.
Hello, everyone. Appreciate everybody joining. This is Meeting of the Minds, Navigating Patient Journeys. You're a patient too. And the reason we put that "you're a patient too" in the title is just to remind us, because I know our audience, we're mostly practitioners or leaders within the healthcare environment. But when it comes down to it, the types of decisions, the way that we build this healthcare system and deliver care affects people just like you and me. So I just wanted to bring that up before introducing Dr. Z. Colette Edwards. So Dr. Edwards released a book that is targeted towards a patient audience, targeted towards a consumer audience on how to navigate within these complex systems. Dr. Colette, just wanted to give you a chance to say hello before we launch into it.
Hi, everybody, and thanks so much, Chris, for this opportunity. Very excited to be here today.
Dr. Colette, by way of background, I'm going to say a Renaissance woman. She just brings many different things to the table with a background in business, writing for Wharton magazine, as well as for many years as a practicing gastroenterologist, has been a medical director, healthcare consultant, working with large health systems, working with payers, working in all areas and working in many facets in areas of the healthcare arena. So this book is informed not just by experience in giving care and as a patient, but also understanding a lot of the business mechanisms and functions that are happening in different parts of the institution.
I have been in a lot of the different stakeholder areas within the healthcare arena over the course of my career. And, first and most importantly was when I was practicing as a gastroenterologist and seeing one-on-one and having that relationship with patients. I have had training in health and wellness coaching and had training in health disparities at the NIH. And I've been a patient like everyone will eventually be unless they're way off the grid. And I have been in roles where my focus was on building, maintaining relationships and finding ways to collaborate with medical groups and with health systems as it related to a health plan. I've done a lot of program design and implementation, and also looked at a lot of digital health companies from a vetting perspective and vendor management in terms of finding solutions for patient populations for employers. And then I've also been in the nitty-gritty as an associate medical director for a large multi-specialty group practice that had medical campuses, satellite primary care offices, had its own pharmacy, a common chart, had its own lab, case managers, et cetera. And in terms of the motivation for writing the book with my co-author, Charlene Rothkopf, who asked me to participate with her after having had a quite interesting healthcare journey over a number of years, having a brain tumor that was first flagged from a seizure, and then she was kind of off and running. But I would say in every role that I have been in, there have been things that have gone very well, but there have been times when things have not gone well, and times when they've gone very badly, and always something to be learned from that, and lots of opportunity for change, enhancement, and improvement of the system so that you are in a position within the range of resources that people have available to them for people to get the best care, the highest quality, have it be affordable, and not burn everybody out and have the system go bankrupt in the process. I feel very strongly that we as individuals and certainly as a collective have a lot more power than we fully recognize. And I think there are lots and lots of examples when people come together and big things happen. And I think that in the middle of our daily lives, and particularly after something like the pandemic, it can be easy to forget the power that we have as an individual to make differences in our own lives and those of our loved ones, as well as the system as a whole.
Well, thank you for bringing that up and sharing that story. One thing that I wonder too is, like, we know the book is written for consumer perspective, for someone who is receiving healthcare services and needs that needs guidance to make sure that they're advocating for themselves right. I wonder, just knowing that we're dealing with the audience of healthcare leaders, change makers, and professionals, what would you say you'd be excited for people to get out of this conversation?
As overwhelming as things can be, as complicated as the system is, as limited as it may appear or actually be as it relates to things like budget, staffing, etc., that once again, people do have the power to make a difference and focus on the patient. And I think that regardless of what part of the healthcare arena you are in, that the vast majority of people went in that direction to do just that. It's not necessarily easy to keep that top of mind always because of life and because of the behemoth that the system has become.
As we go on, let's not forget that it could be a problem of people on the data science side to forget about people and only be looking at rows on spreadsheets and within data frames, and forget that each of those incidents, each of those encounters that you might be seeing or analyzing represents a time that somebody came in and tried to better care for themselves.
I would say another lesson that I learned early on was, go to the people who are going to be doing the job. So when I was an associate medical director of the multi-specialty group practice, and one of the first things that I was asked to do was to take over the billing and coding function for internal medicine. I had gone to medical school, didn't learn anything about it, had gone to business school, didn't learn anything about it. So I had to get up to snuff pretty quickly. But in doing that, I, met with every single person in the department to try to get their take of what has gone on before. What are your ideas? How can it be made better? How can we make the system the easiest for everyone, the most efficient for everyone? I've been a healthcare consultant, and healthcare consultants are fabulous people and can be extraordinarily helpful. But sometimes, as everyone on this call knows, sometimes your best consultants are right there in your midst, and they're seeing it up close and personal every single day. They have all these ideas that they would, love to share, and it can happen much more quickly with greater buy-in at lower cost by taking that opportunity.
Going from that though, like if our goal is to help people better navigate their care journeys and their experiences, what happens if we don't meet that goal? Are there any stories at like an individual or a patient level of what happened when somebody faced too many barriers and wasn't able to sufficiently navigate their care?
If the system is set up with a patient portal, as an example, does the person even know how to get to the patient portal? Does the staff in the office, are you really staffed really for them to pull it off, get it to you quickly, turn that around at a reasonable time? Or has the portal created an issue where it's not happening in the portal, and therefore now people are calling? So now your staff has two things to do instead of one. Or, recently you read about how the results are in the portal before the physician has had a chance to see the results themselves. And sometimes that is the preference of the patient. For other people, it's not. So then you've created like this whole other loop where this was supposed to be empowering. It was supposed to help people. It was supposed to be less work for the staff. It was supposed to be less work for the people the in the office. And for some people, that absolutely was the case, but for a lot of people, not so much. And if you have people who find that when they try to navigate the system, that it is very, very difficult, and what they have as a problem is not something that they can in their day-to-day lives perceive and feel every day, then it becomes a whole lot easier not to continue in the system. So the person who has hypertension ends up, presenting as a stroke,
Mm.
because on a day-to-day basis, yeah, they've been told they have hypertension, but they aren't feeling it. They aren't in pain. They aren't having headaches, et cetera, et cetera. And so, that's just one simple example.
When you're talking to other healthcare leaders, or when you're focusing on helping entities address these problems, do you find that in a lot of cases they're creating disparities, but they're unaware of the disparities they're creating?
I think that the area of health and equity in general is something that more and more people, thankfully, are aware of as, one of the silver linings of the pandemic. But it's not something, if you were in the field, you were well aware of it, and it seemed pretty obvious. But it's still the case that lots of people kind of have that deer in the headlights look. And so an example that I would give is, I was reading data about health disparities, and in terms of access to care, et cetera, for people with disabilities, and how a little bit of work has been done to address that. We have the ADA, we have more ramps, et cetera. But just reading a story about what it takes for her to even get to the doctor's office, in terms of, she was wheelchair bound, getting herself together, getting into transportation when it's snowing, what she's addressing if things have not been shoveled. So for her, that just becomes a massive undertaking. Until I read her story, it was like, yeah, yeah, there are issues, but I never even thought about that one single thing. It's a snow, and it's not even a lot of snow, but it's slush and it hasn't been removed. You have to then address the issue, because it can't be unseen, it can't be unheard.
That little bit of snow that causes a minor inconvenience for some people is a whole lot different realm for other groups of people that sometimes aren't being addressed as much.
Absolutely. There's lots of legislation that has been written because they've had a personal experience, a family member has had a personal experience, a staffer has had a personal experience, a constituent has had a personal experience that brought it to the fore, that made it real for them. Then legislation got passed. So I think that when it's, unignorable, that's when a lot of things change, whether it's at the individual level or whether it's at the group level that has identified a problem. They say, this shouldn't be, it doesn't have to be, and we can make it better.
The nature of that legislation, it just follows a path where something adverse has to happen. And then there's then all of a sudden the attention goes to it, versus like being proactive and kind of understanding where some of those challenges are coming from ahead of time.
And adverse at the level of the individual that people know. Because in the background, it's been a problem for a very long time. But when it's in the background and it's at the group level, then sometimes we don't think about it in the same way. When I know Chris and Chris has a problem, and I don't want Chris to have that problem, and I don't want other Chris's to have that problem.
When it comes to identifying these types of scenarios, and the woman who couldn't roll her wheelchair in the snow, and I'm curious about like your research process for the book and finding the right types of stories to address, and if during that process anything came out and surprised you.
So each chapter has a story related to the topic for the chapter. So for example, one of the chapters is having a baby. One of the chapters is facing health disparities. One is dealing with mental illness. Anything surprising per se, I would say probably the one thing that comes to mind is in terms of resources that are out there that people don't know about, that were set up for a particular reason, and either they were not widely advertised, or I don't know, what the root cause is, but resources that are sitting out there that are, for people who are greatly in need, but people don't know about them, and their physicians don't necessarily know about them, or the system doesn't even necessarily know about them. I would say that that was probably the one thing that was surprising for me.
Are there any examples that come to mind?
I would say coverage for certain services for patients who have a multitude of health issues and health issues related to social issues, like their economic status. In a situation like that, at some point in time, someone thought this was a problem. They actually were able to get something accomplished, get funds allocated. But as we all know, if it's sitting out there and no one's using it, then someone's going to discover, hasn't been used. Do we really need this anymore?
Hmm.
And then it's gone. I think that's when, the having, the role of the social worker comes to the fore. Are they leveraged as much as they can be? Are there enough of them that could solve a lot of problems that I would say directly, but may appear to be indirect issues that definitely impact health, cost of care, quality of care, et cetera?
But if we are in a system where there are programs being made available and there are scenarios that where these programs could help people, but they're being ignored, that's one of those examples where people should put on that healthcare optimist hat and start looking for programs that might fit unmet needs among populations.
There'll be some eye rolling probably with what I'm I'm about to say, but I'll just give you examples in terms of care management programs that and benefits that are available to employees, to patients, to members that actually are very good programs. And when physicians are made aware of them and you kind of walk through, this is what is involved, and it actually can serve as an extension and do lots of things that you recognize would be helpful to your patient, but you don't have the time, you don't have the staff, you don't have the resources, that go unused. And so an example that I would give, from my past was with regard to a large oncology practice that came to I was approached because the contracting was not going well, shall we say, with provider contracting and the practice. It was a huge practice that absolutely, was needed in the network for the greater good of patients. And I was brought in to have the conversation more as a physician to physician. I'm a gastroenterologist, I'm not an oncologist. So I reached out to another medical director who was an oncologist, who was going to understand, the level of the types of concerns, the rationale, et cetera, in a way that I could not. So we were able to address that. But what came out of that was a conversation of how can we work together to provide more resources and support to your practice. And so we were then able to assign specific case managers to that practice, and actually ended up with a co-branded brochure with the practice so that patients would know this practice exists. And because the physicians in the practice felt comfortable about it, they knew what it involved, were then going to make referrals to the program. And the referrals from physicians as a source versus claims, which is always going to be delayed, that skyrocketed as a result of that. Now, would anyone have ever imagined that you go from a very contentious scenario where the group was going to walk to a co-branded brochure and referrals? That's not going to the way that you would typically expect that story to end. So, it's even with little things like that I know that we can make things happen.
Are there thoughts on newer engagement models to make patients aware of some of these programs?
An example that I can give you of engaging people is a startup. It is focused on the engagement of patients, lower socioeconomic status, where they actually have, once again, focus on people. They've gone out to people and had conversations where the people are and asked them what are their needs, what are their concerns, what are their fears. After having those conversations, the percentage of people who actually followed through, because they tracked it, significantly increased. Now, you can't have that type of model necessarily at scale, but the next step after taking that is taking that information and synthesizing that in a way that can be applied at scale. And I think that it's also finding out what people's preferences are around communication, because there are lots of people who would respond to a text and not an email. There are lots of people who will respond to paper and not anything with regard to technology. But it's also important not to make assumptions, because there are a lot of people who are over the age of 65 who are very much engaged with technology. And there are lots of people younger than the age of 65 who still want the desktop version. They don't want the app. So it's really finding out from people, how do they want to engage, as opposed to thinking this is going to be the most efficient, cost-effective way to do things, which may sometimes be the case. And it's also really getting that information up front about the person's perception of what the problem is. So you're a diabetes program, you want to get down that A1C, you want to increase medication adherence, but does that have anything at all to do with the patient's concern and whether or not they're going to take the medication, and if they aren't, why they aren't? Is it because they forget and they need reminders? Is it because they aren't so sure about the medication? Is it because they got side effects? I mean, technology offers lots of ways to communicate with people, with lots of ways to engage with people. So you may go in with an assumption that it's going to be this and find out that it's going to be something else, and you end up trying it. And particularly with technology, it is often the case that it's incredibly easy, inexpensive, and you can change things quickly. I mean, that's some of the beauty of technology.
We've been talking about these stories around navigating care, but I just wonder, what are some examples of health systems or payers that are getting this thing right, that are, or just some examples of system-wide successful navigation that's being offered for patients that people can kind of take examples from?
So I'm thinking of a health system. One thing that stands out is they started off with a 10-year view, and started off with, what are we going to do next year, or 2 years, or even 5 years? Now, obviously, when you have a 10-year view in healthcare, it's going to change, but they were looking longer term. They were also looking at a lot of different factors that typically people were not considering. And they were also listening a lot to patients and what their needs were, and the best way to get them what they needed. So people talk about, meeting people where they are. They literally were doing that. And they also put money behind, if you think that you are delivering high quality, cost effective care, then kind of separate from a capitation model per se. They were willing to put, money down to stand behind the work that they were doing, which is a powerful statement in and of itself, and a statement that not that many people make. And certainly at the time that they started doing things like that, no one was saying that, no one was doing that, and then actually following through. I can think of a health plan that has done extremely well with their medical home program. The quality of care did go up, the cost of care did go down, patient engagement went up, and they invested enough money to make it really be worthwhile for physicians to make the changes that are required to operate as a medical home. Conceptually, it sounds great, but it's a lot of work to set up the workflows and get the staff aligned and have the trigger systems, et cetera. And they really understood it. They put enough money down that made it clear to the physicians that they understood what they were going through and that it was going to be worthwhile at the end of the day after they made all of those changes, which did make things better, that financially, not only were they going to be whole, they were going to be more than whole.
What keeps an organization focused on seeing an initiative like that through to the end?
So that they were focused on the patient, and they took care of the people who were taking care of the people. Because just, people always say that. How often do people actually do it in any industry, not just healthcare? So I can think of a restaurant chain where the founder of the chain, that was his mantra: take care of the people who take care of the customers. And he actually did it, and it worked out great. He had one restaurant to another restaurant, multiple chains with different cuisines, and benefits for their waiters and the whole staff, et cetera. It's just when there are things that we know, but for a multitude of reasons, and the data has been pulled, the research has been done, the white paper has been written, but then it comes time to, are you really willing to take that step when you look around and no one else is doing it? And so, I'll give an example that I find, and this isn't just for healthcare either, but this is one that really kind of still sticks in my craw decades later in healthcare, where in a New England state, at a time when malpractice premiums were just staggering and growing by leaps and bounds for anesthesiologists, the anesthesiologists in that state, through their medical societies, et cetera, came together, developed pathways, developed guidelines, worked with the malpractice carrier, and came to agreement that, number one, if they follow these guidelines and pathways, obviously with the ability to go off the pathway based on a particular patient, then the malpractice premiums would be reduced, and that if someone was sued, the malpractice carrier would actually defend them in court, because sometimes those things get settled whether or not the physician wants that to happen. And what happened? The quality of care went up, adverse events went down, malpractice premiums went down, and in a relatively short period of time. And so I said to myself, for sure, when the anesthesiologists have their national meeting, this will be a story that will be told as one of the presentations, and then in relatively short order, this will be happening all across the country. Nope, not then, not now. Even when you see those success stories, there's still something that holds people back from taking that on. People go into healthcare for a lot of reasons, but I think it starts with the patient, the consumer, the member, as their area of focus and with a goal of helping that person in some way. The system is perfectly designed for us to be where we are. It's a system that we created, and it's a system that we can fix. Is it going to happen overnight? No, but but we can't afford to not do more and do it more quickly than what we're doing right now, given where we are right now and given the direction that we're headed.
Well, I appreciate that answer. And honestly, I appreciate the many different stories that you've shared that highlighted challenges and breaks in the system, but also I hope have given some new North Stars to some of the folks watching to say that there is the power and ability to make change. And sometimes it will be fraught with some contention and things like that, but there is the potential for change. We give a magic wand out, and with that magic wand, you can change one thing about the healthcare system. What would that be?
For people to remember the North Star and see people as people. You know, each person encounter that you have, whether it's with the patient, whether it's with staff, whether it's with the janitor, regardless, because once you see people as people, then it makes it harder not to do some things that should be done. It also makes it easier and is encouraging and gives you motivation and gives you inspiration and gives you encouragement to keep moving forward.
Thank you for sharing. I think that goes even deeper than like system-wide incentives, is the way that we view people culturally like that. That's really what drives the desire to even make those incentives that result in better outcomes in the first place.
Well, and the book, just to kind of end it as it relates to the book, people shared their stories because they wanted others to not go through what they went through, right? They didn't have to share their stories. They didn't have to tell us a thing, but they wanted people to know their stories so that the next person coming along could learn that lesson, do things differently, ask this question, whatever it was, to make it better for other people.
Well, strongly appreciate that. And Colette, appreciate this conversation.
Thank you so much, Chris.
Thank you.